the last presentation of the afternoon because the final one is cancelled. We have Dr. Sandhya Panch, who is Associate Professor in the Division of Hematology in the University of Washington, I think largely taken over Terry Gernsheimer's practice. She's involved in transfusion and autoimmune cytopenias with a very special interest in ITP, who's going to tell us about, now this says new studies to perform in ITP, but she says new tests in ITP, so I'm not quite sure what the presentation was. I thought it was going to be new studies, but anyway, you can tell us, Sandhya. Thank you.
Thank you, Drew. Thank you all. Can you hear me okay?
Yes, we can hear you.
That's great. Yeah, so I saw Dr. Kudar's presentation was on new studies in ITP, and in my discussions with Thomas, I think there was interest in sort of biomarkers and tests, which is my area of interest. And so thank you for the opportunity today to present on new tests. And I say new in quotes, as some of these testing strategies are not necessarily new. Instead, we may be time to revisit already available techniques in ITP management. These are my disclosures. So ITP, as we all recognize here, is an autoimmune disease characterized by low platelet counts and may be accompanied by variable clinical expression from patients being asymptomatic through to developing life-threatening bleeding complications, as well as impacting other health-related quality of life measures. In the 50s and in the 1950s, the pathogenesis of ITP was thought to be mostly autoantibody mediated, for which all patients received steroids between the 50s and the 80s and eventually a splenectomy. However, in the recent years, studies have helped elucidate a number of features of the disease's etiology. Starting in 1981, IVIG was introduced, followed by rituximab, TPO-RAs, and most recently fostamatinib and rilzabrutinib in the US. Currently, FcRn blockers, CD38 monoclonal antibodies are being developed with promising initial results. So the cartoon here on the left with the blue boxes demonstrates all the different treatments available based on an increased understanding of the pathophysiology of disease. But the lack of universal predictive biomarkers for diagnosis as well as response to treatment represents a major unmet need in ITP. And this is even more important today, as I showed you in the previous slide, with the growing number of therapeutics available to improve patient management, with the aim of personalized medicine, that is to offer best treatment to the patient at a given moment. It is important for clinicians to have reliable tools to help with therapeutic decision-making based on deeper analysis of DNA, RNA with transcriptomics or proteomic approaches that we can increasingly leverage in the current times. This was a paper by Dr. Jim Buzel and Dr. Miltadios. The differences in diagnosis and management between ITP and leukemia are shown here in the article and are striking. In this age of molecular diagnosis, prognostication, and application of targeted therapies, and ITP seems like a throwback to the way medicine was practiced 40 years ago. Leukemia diagnosis and management, on the other hand, have evolved substantially over the past 30 to 40 years and now are relatively precise. Currently, ITP diagnosis and management depend very much on the experience and preferences of the hematologist. There are no universally useful molecular tests and no agreement on which test needs to be performed and no consensus on treatment. However, the increasing ability to do single cell and DNA, RNA studies and flow cytometric dissection of small populations of cells could radically change the approach to ITP if critical distinctions were uncovered. And again, here you can see how the molecular typing, for instance, in ITP, or even subtyping based on platelets or other cells, is largely non-existent even at this point. So the question is, instead of merely sequencing therapies, especially in refractory ITP, can we use biomarkers to predict or preempt responses versus non-responses in these patients? Studies have evaluated various cytokines, cellular subsets, gene polymorphisms, occurrence and extent of platelet decylylation to evaluate response to glucocorticoids. Younger age, higher peak postoperative platelet counts and steroid response at baseline have been correlated with responses to splenectomy. And recent studies have more systematically evaluated newer lines of therapy and response predictors, which I will show you in the next few slides here. So this was a study done by Hani Al-Samkari and David Kuder at MGH. You can see the study was to evaluate if thrombopoietin level predicts response to treatment in ITP. And this was a ROC analysis that demonstrated TPO thresholds of less than 136 for L-thrombopeg and less than 209 for romiplastim optimally discriminated between responders and non-responders, wherein responders had lower levels than these thresholds, whereas non-responders seemed to have levels that were higher. Interestingly, most non-responders who had high TPO levels did respond to the addition of low-dose prednisone. Dr. Gernsheimer at our practice would always and has published on this as part of a small retrospective analysis that low-dose prednisone seems to stabilize TPO responses in patients with refractory disease. The mechanism of how prednisone works here is unclear, but at least it appears that TPO levels may be somewhat predictive in responsive in refractory patients of whether or not they would be. It would make sense to add or increase TPO. Platelet sequestration and response to splenectomy has seen a reawakening recently with at least 4 new studies in this area and a meta-analysis early in this decade. Indium labeled scintigraphy demonstrated that platelet sequestration, I show you one of the 4 studies here, platelet sequestration was associated with a 2 times greater response at 12 years than in case of non-splenic destruction. So 87.5% responses among splenic sequestrers versus 45% response rate. And this is shown in the relapse-free survival Kaplan-Meier curve here on the right as well. Now, the ratio, the splenic to hepatic platelet uptake ratio of greater than 1.4 was both 90% sensitive and 77% specific as a response predictor for splenectomies. Conversely, the absence of splenic sequestration was associated with a 3-fold greater risk of relapse after splenectomy. Interestingly, platelet decellulation, which can be measured by flow cytometric techniques or was in this instance, may also be a potential biomarker for non-response to splenectomy. As we understand from basic pathophysiologic studies in ITP, platelet decellulation occurs via the Ashwell-Morel receptors in the liver. And so the thought is that when there is excess decellulation, the platelet destruction largely occurs in the liver, and therefore splenectomy may not be as helpful. And of course, indium label scintigraphy can look directly at splenic sequestration and predict it between these 2 tests. If appropriately validated, I think there is a lot of useful information to be gleaned. I would certainly recommend it to my patients before they undergo something as invasive as a splenectomy in the current times. So something to be considered as well. Unfortunately, in the US right now, there is no way to perform the test, due to insurance issues as well as the cumbersome nature of the test. I don't believe that any radiology groups do this. Now, of course, Doctors Gernsheimer and Slichter actually showed this about 35 years ago now in their study with similarly indium-labeled autologous platelet sequestration patterns, with the hepatic sequestration pattern associated with ineffective splenectomy and a splenic sequestration pattern associated with effective or successful platelet count responses after splenectomy, suggesting at least that this procedure should be incorporated into algorithms before considering splenectomies to prognosticate for patients. This was a study evaluating daratumumab effect on T cells. And this was in autoimmune hemolytic anemia, but one could envision similar principles being applied to ITP as well. Daratumumab, a CD38 monoclonal antibody, results in plasma cell suppression and decreased autoantibody production. Now, CD38 is also expressed on activated T cells and influences the immunomodulatory effects, we think. In this particular study, not only did they demonstrate responses of up to hemoglobin responses in up to 50% of patients within 2 weeks of starting daratumumab, they were able to immune profile these patients and evaluate their T cell CD38 expression. It appears that depletion, complete the CD38 T cell depletion, altered T cell subset differentiation, as well as diminished T cell activation and proliferation were associated with the response. Now, the sample size was really small. They did demonstrate that in one patient in whom the CD38 T cells recurred or reappeared, it seemed to coincide with disease relapse in the patient. So this is something that we are also evaluating along with our hematopathologist. Interestingly, CD38 stains are normally done on the B cell tubes, and so nobody typically stains T cells for CD38. So on our routine flow cytometry, this is difficult to obtain, but we are making exceptions these days in ITP patients with peripheral blood flow as well, where we are systematically evaluating CD38 T cell expression and trying to correlate it with outcomes after treatment. This was a study in refractory ITP, again, heavily criticized for the study design itself, using a CD38 monoclonal antibody. The study itself was criticized for rapid responses being due to concomitant high-dose steroid use. But as part of correlative analyses, they demonstrated, in addition to some of the extensive immunophenotyping they did here, as shown on the right, that glycoprotein 1b9 antibody positivity was associated with a significantly higher relapse, almost 67%, compared to glycoprotein 2b3a antibodies, 29% relapse. Of course, these antibodies were it's important to point out here that these antibody measurements were indirect, which means that they measured antibodies freely circulating in plasma, not necessarily antibodies bound to platelets. And so, what is the right way to perform these tests? Again, there was an ISTH symposium that was convened in this context a few years ago, and glycoprotein specific direct platelet and autoantibody testing performed using ISTH recommendations in patients meeting ASH diagnostic criteria is thought to be both sensitive and specific for ITP diagnosis and reliably confirms clinical remission. This was a study again done by the MGH group, Hani and others. Sorry, the reference is wrong here. Hani and Dave Cooder. It was a retrospective study of platelet autoantibody testing using ISTH criteria in adult patients with ITP, wherein of the 986 platelet autoantibody assays performed, sensitivity and specificity of a positive test result for the diagnosis of active ITP were 90%, so 90% sensitive and 78% specific. Further, they did logistic regression analyses, which revealed that more positive autoantibodies predicted for more severe disease. However, serologic testing did not meaningfully predict treatment response to glucocorticoids, IVIG, or TPO-RA. And so there was some demonstration of sort of epitope spreading in more refractory disease using this particular test. And this is done by the PAC auto test that is done at Versity in Wisconsin. And all of these 900 plus cases or tests were done using the PAC auto assay, which again meets all ISTH criteria, and it's a direct evaluation of platelet antibodies bound to the surface of these platelets. Now there are, the test itself is quite cumbersome, and I can get into the details at some point, from a transfusion perspective as well, because it's the transfusion service there that performs these tests. So this is we conducted cytokine and transcriptomic analysis to evaluate response characteristics in refractory Weyha and Evans patients who were treated with fostamatinib, a Syk inhibitor approved for use in chronic refractory ITP. This multi-center study, which showed a 64% response rate, we identified upregulated phagocytosis pathways post-treatment, as well as higher macrophage migration inhibitory factor levels in responders compared to non-responders. And that seemed to align with the mechanisms of the drug itself. We also identified a trend towards higher fostamatinib response for some reason among Hispanics. This was a retrospective study conducted at 6 tertiary care referral centers in the US. The transcriptomics and cytokine analysis were performed in a subset that had samples set aside. But certainly appears to be a situation. I mean, it's somewhat early to make strong conclusions about these data, but we were able to confirm some of these in multiple different ways. We also evaluated by single cell RNA sequencing subsets or fractions of cells that were different among the responders and non-responders. We didn't have baseline samples on these, but we were able to compare these data to healthy blood donor controls. And we found, similar to Dr. Nicola Cooper's study, we found an increase in TEMRA, for instance, TEMRA cells in the chronic refractory Weyha patients who were non-responders, whereas the TEMRA cells were much lower in responders. In addition, we found differences in monocytes as well, where HLA-DR low populations were significantly increased in non-responders. Same thing with effector cells, T effector cells were higher in non-responders, paradoxically, and naive cells were higher in the responder populations. So some interesting data there, and how this translates to ITP would be useful to evaluate in the context of a study. I will probably go through this quickly here. This was similar data from a patient with refractory ITP post-hematopoietic stem cell transplant. This was a 50-year-old female, 8 months in remission after allo transplant for AML, and developed refractory ITP with bleeding 1 month after the COVID vaccine. You can see here in the graph, we threw pretty much everything at her in the first 5 to 6 months without any responses there. Significant. She continued to require, unfortunately, had bleeding and had counts in the 0 range, and was getting platelet transfusions almost every other day. She received 1 dose of daratumumab, as shown more towards the right here, and we saw a blip of an increase in her counts. So we said, well, maybe we need to continue giving her daratumumab, and we gave her an 8-week course. Now, we don't know, of course, whether this was waning vaccine effect because this was right around 6 months or so, or if it was actually the daratumumab, but we were able to collect cytokines and transcriptomic data from her at 2-3 different time points before and after dara treatment. And interestingly, we found a significant decrease, and this is an N of 1, of course, but significant decrease in JAK-STAT signaling pathways, MAP kinase, mTOR signaling, and Treg signaling, if anything, increased before and after DARA treatment there. We found differences in cytokine patterns as well that were suggestive of a reset occurrence post-recovery. And the possibility to maybe combine these tools to evaluate responses to therapies in refractory settings. We applied and evaluated several of these omics-based approaches and identified differences in druggable pathways in untreated ITP patients, which can then be extrapolated potentially to other settings as well, pre and post treatment. And these analyses were 2 presentations by our team at ASH last year, for which manuscripts are in preparation. So this was the first study here. We collected peripheral blood samples and buccal swabs from primary ITP patients, and in a 1-to-1 ratio, compared it with age and sex matched healthy controls. We did targeted sequencing with a panel of known IEI genes. We did transcriptomic analysis, cytokine assays, as well as single-cell RNA-seq in these patients. Here are results. Sorry. Here are results now for from the IEI panel. Interestingly, it appeared that there were more controls without mutations there. You can see many more of the nuns in the control, so no mutations in the control group than there were in the case group. It didn't really show any major differences in variants between cases and controls with regard to pathogenic or increased risk alleles or variants of undetermined significance. Next, we examined the transcriptome. We again found more data in terms of differences in the groups itself. This was just a cluster of patients, of all of our patients and controls that we dropped into the transcriptomic analysis. Among the female group, we identified two distinct clusters. You can see here circled here. In the male group, we did not have sufficient numbers to see patterns. And so I will focus and show you data on the female groups for now. There were 17 cases and 17 controls. Examining the clusters within the female group, they appear to be separated by age, and the average age among the older group was 64.5, and they seem to cluster with controls, interestingly, across all ages, while the average age for the younger group was about 36.8. So 64 and about 36 or 37. We also compared by age of onset of disease and platelet count, and there were no significant differences between the clusters when we adapted a p-value threshold of 0.01. So it certainly did appear that these clusters were age related and age at the time of sample collection. Next, we examined the gene pathway activity in the younger versus older clusters. And in the right panel, we have highlighted potential druggable pathways which were identified, like JAK-STAT pathway, which seemed to be overexpressed in the older group compared to MAP kinase, mTOR signaling, NF-kappa B signaling, etc., which seemed to be overexpressed in the younger ITP population. Additionally, we detected T-cell diversity in cases and controls. As expected, we observed an age-driven decline in TCR repertoire diversity within the control group. However, this decline was not evident in the case group, and there was a trend towards reduced diversity in the younger cases, paradoxically, compared to controls, while older cases showed higher diversity than controls. For cytokine assays, we found minimal differences. Among the 48 cytokines and chemokines analyzed, only 4 showed significant differences, and there were no differences observed between older cases and younger cases. As part of the single-cell RNA sequencing site-seq assay, we have so far analyzed 7 cases and 6 controls. After quality control, we got 17,000 plus cells, which divide into 17 clusters and 7 main cell populations, which are annotated here on the right. In further analysis, we found here that cluster 0, which is shown in the blue, exhibited significant differences between cases and controls as well as across our case age groups. We identified smaller differences in CD8 T cells and monocyte populations as shown here in the red and in the green. You can see differences in cases and controls, but the blue was most striking and statistically significant. In the figure on the right, you can see cluster 0 percentage was increased in cases and with older age as shown here. So what is cluster 0? Cluster 0 comprised of a mix of CD4 positive T cells, which includes T central and effector memory cells and Th17 cells. And Th17 cells also appeared to be enriched in the younger cases. So again, demonstrating here that these were the cell clusters, T central memory and effector memory, and Th17, which appeared to be enriched in the younger cases. So this is our summary so far in this pilot study of multi-omic approach, which shows promise for precision medicine in primary ITP. We observed no differences in the number of variants between cases and controls, even though there was a trend towards controls being more likely to have no variants. T cell specific pathway analysis showed clear differences in female patients, which seemed to cluster by age. And cytokine data were inconclusive with only minor differences between the groups. And there seem to be clear differences in CD4 T cell populations between older and younger females. So, what are the next steps? We are currently exploring differences in druggable pathways. Under this, of course, several questions need to be addressed. Could these differences be caused by age-related hormonal changes in females? There have been publications on this, including papers that Dr. Buzel and others published in the context of rituximab. Can we explain sex-based differences in treatment responses? Again, in the context of rituximab, this has been explored. Should we use more mTOR inhibitors in younger adult patients? I believe Dr. Michelle Lambert had a paper that younger ITP patients seem to respond better to mTOR inhibitors like sirolimus compared to older ITP patients. Interestingly, we saw JAK-STAT inhibitor pathway activation in older compared to younger patients, and so maybe this is a pathway to target in older refractory ITP. There have been evaluations using some of these agents or one of these agents in refractory ITP. And finally, is there a role for pathway-specific inhibitors? For instance, PI3 kinase inhibitor leniolisib is approved for an inborn error of immunity, a condition called activated PI3 kinase delta syndrome or APDS. And so the question is, could we repurpose some of these agents, especially in patients with chronic refractory ITP who have some of these pathway activations, and determine if that is a way to tailor therapies in our refractory patients? This was a paper from Dr. Cooper's group recently, again, aligned with some of our thought processes here. Their paper summarized it as a study of evaluating how we can reduce misdiagnosis of ITP, which often occurs with inherited thrombocytopenia and primary immune deficiency syndromes. The study investigated whether genetic testing for inherited thrombocytopenia or primary immune deficiency can enhance diagnostic accuracy in ITP and guide treatments. They performed whole genome sequencing and targeted panel sequencing in a cohort of 80 participants with chronic ITP. And you can see here about 11% in their original cohort and about 8 to 9% in their replication cohort had a pathogenic variant identified. And the findings had implications for clinical management, wherein they were able to avoid immunosuppression in ones who had ANCAR D26 or ETV, TUB1, and so forth, or even determining eligibility for allogeneic stem cell transplant in one of their cases with UNC13D. So, their findings demonstrated that gene sequencing did identify diagnostically relevant variants in patients with chronic ITP, and identification had an impact on guiding treatment decisions and improving patient outcomes. Abatacept and leniolisib, these are drugs that have been used in other contexts. Leniolisib to treat activated PI3 kinase deficiency. Abatacept has been used in combination with rituximab, also largely used by the rheumatologic community. Leniolisib is a selective PI3 kinase inhibitor which suppresses AKT3 phosphorylation and mTOR and other pathways downstream of PI3 kinase in cell lines. And has improved immune dysregulation in patients with APDS, a monogenic disorder. I had a chance to be involved in the study when I was previously at the NIH, and we demonstrated decreased AKT3 phosphorylation and improvement in cytopenias, along with other changes, of course, decreased lymphoproliferation, improvement in fatigue, and so forth. And so the question is, can some of these drugs, abatacept has been developed for rheumatologic conditions and also been used recently in CTLA4 haploinsufficiency. successfully used in select cases of post-transplant autoimmune cytopenias. At ASH last year, there was a talk using sirolimus upfront with dexamethasone as a way to suppress mTOR pathways in these patients, all as examples of pathway-tailored therapeutics to optimize response and minimize serial drug exposures and toxicities potentially. The cartoon here on the right also shows leniolisib pharmacodynamics that are time and dose dependent. Again, with the activity of PI3 kinase AKT pathway influencing cytopenias in a dose dependent manner. You can see as dose it was increased of the leniolisib, there was decrease in PI3 kinase activity as well as downstream AKT phosphorylation and so forth. And so again, something to consider. Overall, I've just summarized for you some of the more recent studies in the context of using quote unquote newer tests or biomarkers in evaluation and management of ITP patients, TPO levels to direct TPO array therapy, for instance, in refractory cases, splenic sequestration studies using indium-labeled scintigraphy and or platelet desylation assays before splenectomy, maybe using T-cell CD38 expression before daratumumab. These are very preliminary data. Direct glycoprotein-specific autoantibody testing, which should be explored further. I think this test has fallen by the wayside because of indirect autoantibody testing often. Phagocytosis pathway expression, macrophage migration inhibitory factor levels potentially before fostamatinib, genetic sequencing, transcriptomics, and again, these are very preliminary data, but it would be interesting to see if we are able to risk stratify ITP patients just like we do in leukemias. And then PI3 kinase, mTOR inhibitors, CTLA4 analogs in selective cases where these pathways are over or underexpressed. So as next steps, we have ongoing efforts to systematically immune profile adults and children via our autoimmune cytopenia registry and biorepository, which I'm trying to create to advance our precision hematology approaches as a way to improve ITP patients' lives as well. I'd like to acknowledge the village that was involved in this work and thank you to our research participants and blood donors for their generous contributions, and thank you for your attention. Happy to take questions.
Thank you, Sandhya. Okay, open for questions. Thomas has a question. You put your hand up. You looked like you wanted a microphone. No. Give him a microphone. Okay. Who should we give it to? Dr. Kapoor, would you like to ask a question? Dr. Semple's thing here. Dr. Semple has one as well, I think. Yeah, Dr. Semple always asks a question. It's like... Okay, right here. Sorry, Sandy. Hold on. Here he comes.
Dr. Semple, you may know the answer already. You're on the slide, by the way.
Right, Rick.
Yeah, thank you for presentation. And I think a lot of interesting points. Also the CD38 on the T cells. I completely agree that's an important angle to investigate. Regarding your autoantibody testing, at least in Europe, I think we are more of the opinion that the MAIPA is a better test regarding sensitivity and specificity for testing. And the direct MAIPA actually correlates quite well with the indirect MAIPA as well. So in case, that's not always possible to do the direct testing that way, the indirect testing is still also rather useful, I think.
No. Thank you for saying that. And I think you may have published in this area, right, Dr. Kapoor, with the Sanquin group, if I'm not mistaken. Yeah, so I mean, in the, I meant to say a lot more about testing for autoantibodies because this is dear to my heart as well. The problem with the PAC auto test is that you need a lot of sample, 30, 40 cc's of blood because if these patients are, first of all, you need a lot of blood and they cannot be very thrombocytopenic because they are specifically testing for autoantibodies attached to the platelets, right? And so I think those are pretty big caveats because you really start thinking about this test when patients' platelet counts are quite low. And so the other thing is they should not have been transfused. So all of these are caveats. Whereas I think with the MIPA assay, as you point out, if we can get it to be work as well as the direct tests, I mean the direct MIPA and the indirect tests, I think if the sensitivity is as good, we have not attempted it at our center, but it'll be useful. I don't know if anybody in the US does it. We have only been able to send samples over to Versity and the Red Cross, and both of them seem to have not so great sensitivities for the indirect assessments.
Yeah.
Sandhya, we have a... Oh, sorry, you said...
Yeah, just one last quick comment on the Chinese New England study, where you rightfully commented on the flawed design there. I would also be cautious on interpreting the glycoprotein 1b9 associations that they found in this cohort. So, yeah, I'm rather skeptical about those findings, I have to say.
Absolutely. Yeah, I think, I mean, I mentioned that as a, I mean, I think their intentions were good, I think, as part of the study, but there were a lot of study-related challenges. And again, these were indirect assessments to begin with, but I don't know if there were more, things hidden in there in terms of the test itself. But
Okay.
Yeah, thank you.
Dr. Audia from France is online. He's been with us for quite some time. He has a question for you, Sandhya.
Hello, Sandhya. Thank you for the really nice talk. Focusing on part of your data, you spoke about mainly about women for some of your results. So my question is, did you observe any differences between male and female from the immune point of view, of course? Thanks.
Yeah. Thank you. Thank you. Yeah, unfortunately, we didn't have large enough numbers. We just, recruited contemporaneous and consecutive ITP patients who came into clinic, newly diagnosed patients, because those were the ones we could get baseline data on. That was the goal. And as you see on this graph, we had 5 cases, 5 controls. We have a few more males now, and we probably have to reanalyze these data. But when we put everybody into the cluster, it didn't seem like they separated or that we found differences in signals. We did look for it. On a slightly different note, I just wanted to say with CD38 expression as well, I know this was a paper that was evaluated. I don't know if other groups have looked at this. When we have begun, since we have begun our systematic evaluation of T-cell 38 expression, it looks again like there are age-specific differences. And so that's something that is already standing out. And so I don't know how easy it's going to be to also, and there has been mention of age-specific difference in T-cell CD38 expression as well in the literature. So we're still exploring these as well.
Okay, any more questions? I mean, it's a really interesting area. We're going to have to standardize. A lot of these tests are like experimental, and the technologies vary from lab to lab and country to country. We're going to have to just think of like a few things to measure and then all do the same thing using the same sort of techniques. Otherwise, each person will be doing a completely different assay to the next person. But I think diagnostically we're in the 1950s, and therapeutically we're right up to date. It's just that's the depressing part about this disease, if it exists. So I think on that note, Sandhya, thank you so much. That was a very interesting presentation. Thank you for joining us. I think we're going to wrap up now. Thank you, and say...